Hello and welcome back to the Advancing Healthcare Innovation Show. And I'm your host, Michael Stamatinos. And if you're new to us, super excited to have you here. And reason being is we're bringing you some of the most exciting conversations with leaders that are in the front lines, painstakingly shaping the future of healthcare. And we happen to be really passionate around healthcare innovation, adoption, access, and leadership. And if it's your first time tuning in, let me just give you a little bit more context about what we're trying to do here. So we're a healthcare innovation company, and our focus is really bringing real stories of people that are in healthcare that are trying to innovate to life and giving them the platform to share their story with our community. And if you haven't checked out any of the historical interviews, make sure you do that. And if you want to check out any of the new episodes, make sure that you hit the subscribe button now so that they come directly into your inbox. And as part of our commitment to just staying up with the latest and greatest advancements and solutions and stories that are happening within our industry, our job is really just bringing on board innovative leaders that are pushing boundaries and shaking things up. So joining us today is Casey Fisher. Casey is the Chief Operating Officer of Intuitive Health. And Casey's got just an in-depth knowledge of the workings of standalone emergency rooms and local urgent care centers. And it's really underneath his leadership where Intuitive Health has pioneered a very unique model, a retail approach to blending emergency and urgent care, really just eliminating the confusion for patients and really setting new standards when it comes to community care. And Casey's experiences are vast. And at the end of the day, what he's really been focused on is around this concept of patient journey. And whether it's managing operations and implementations or collaborations with health systems around the country, it's really just been this holistic understanding of keeping the patient at the center of the landscape that has really allowed them to build a patient-centric platform. And his efforts are tireless, and he's really trying to make healthcare more accessible and fair. So Casey, it's great to see you again. How you doing?
Yeah, Michael, thanks for having me. I really appreciate it.
Yeah. So let's dig in a little bit. I mean, your background's super interesting, and I've given a little bit of a high level, but what got you into this specific niche of healthcare? And then we can kind of go from there.
Yeah, so I was really fortunate. The three physician founders of our organization had this novel idea of combining urgent care and emergency room all under one roof, but closer to where people, lived. And so basically, they've worked at some of the major health systems in the Dallas-Fort Worth area. They worked at some of the first freestanding emergency rooms. Realized in both cases, there's a lot of patients that show up here that didn't really need to be in an emergency department, and then they get a big bill. So if they were going to do something in their communities in which they live, they wanted to have something to where, like, they were in the grocery store and they saw a patient, their neighbor they had there, they weren't going to be, oh man, they're going to get a really big bill for that strep throat they came and saw me for, which was kind of, or that, minor fracture. So they wanted to do something that was fundamentally fair, and asked me if I wanted to be a part of it. And I said, man, that sounds great. From my time, I started out as a CT X-ray tech and working in a hospital and covering the emergency department. There was a lot of things coming through that ED that you're like, man, it's terrible that they're like having this high bill for something that's fairly simplistic problem. But in that moment of ouch, when you're trying to determine like, hey, where best to take your loved one or yourself, a lot of times you default to that highest level of care, and then 45 days later you get stuck with a big bill and you didn't nearly need it. So they wanted to do something that was a little bit disruptive, that would treat people fundamentally fair. Obviously, something I could get on board with. And from there, it's been perfecting that model. We started out on our own, just doing fully owned locations in Texas market where you actually can be a licensed emergency department, not part of a hospital. It's unique. And then once we kind of realized that we could not only replicate this model in two, but then six locations, and we kind of codified best practices. How can we partner with health systems across the country to bring the same value add to those communities where there's a much more greenfield opportunity than the very competitive landscape of the Dallas-Fort Worth area? And so, going forward, we now have 29 locations in operation today. We'll open another 7 to 10 every year for the next few years. Multiple health system partnerships across the country, and doing the same thing, which is taking that value-based operation, putting the patient first, not only at the time of service when they're visiting there, but then 45 days later, the bill that they get is fundamentally fair for the services they received. Kind of disrupting the healthcare landscape in that way.
That's really interesting. I'm curious, are there any other states that are similar to Texas with respect to licensing that is available for freestanding emergency rooms? Are there any other states that operate like that?
To do it independently, you can do it in Colorado, and there's a way to do it in Arizona. Um, but going in as an individual disruptor and at like a single location, you're going to be viewed with a little bit of like, what are you doing from a payer perspective to buy into the model? So it's for us, it's been partnering with major health system brands across the country and taking our operational model, integrating it in with that health system so it's seamless, so we can bring that value there. It's been the way that we've gone forward. So that gives us the most path for growth and allows us to bring the most value across the country by doing that partnership.
I mean, it's interesting to know that now you're partnering with health systems. Initially, moving on, I mean, how much time did you think that you guys needed to really, I'll just say, really find your groove? And what type of data do you need to sort of present, whether it be to payers or even to health systems that are future partners, in order for them to feel like there's a ton of value there?
Yeah. So one, it's incredibly difficult to compliantly charge people less from an emergency department setting. So we had to go figure out how to do that from a conditions of participation standpoint to be able to make sure that we could appropriately and compliantly bill Medicare and Medicaid folks that came through there. So that was one, is figuring out that piece. And then two is making sure that we could put our cost operational model in there to be efficient enough to be able to have it sustain itself. And so we're able to do that at first on our own. And then it really came down to key metrics that drove the overall business. So your urgent care door-to-door times, basically how quickly can you get those low acuity patients in and out without them feeling like they're rushed. That's the real art to the piece there. And you can for sure move people through, and if they don't feel appreciated, they're not really going to appreciate you and they won't come back. So then really focusing on those service levels, being able to show consistency across multiple locations in our Dallas-Fort Worth market initially. And then we had some great first partners like Presbyterian out in Albuquerque, New Mexico, Riverview in Indiana, who took a chance on us early on that we could go through and get some of these results. And then we executed on that. As it relates to a payer standpoint, we use an objective resource-based criteria. So the criteria are the same. So like, give you for instance, if you come in and I'll use actually my son's instance. He decided he wanted to be like Big Brother and jump off the slide, caught his toe, and fell and broke his arm. Right. So we took them in there, and my son just had a small distal radius fracture. It was non-displaced, got splinted, got to follow up with ortho. He didn't have to be sedated or anything. That was an urgent care visit because we could do so. Now, if my son had to be sedated and I needed like sedation and I needed continuous monitoring and those things, it's more of an emergent case, right? And so we use those objective resource criteria to determine which way. And over time, we've built up 15 years worth of data that is very consistent across multiple markets that allows us to speak with confidence on what's going to happen based off our assessment before we go in. It gives our partners and payers also some credence to what we're doing too, because they can go check references really easily. We'll happily do so because it's pretty easy when you practice what you preach, which is what we've been doing this entire time.
I'm just very curious because I can tell you from multiple personal use cases where I've got young kiddos that you have to take into the urgent care, and they're saying, "Hey, this is like you got to go to the emergency room." I can only just tell you how much of a disruption that is to, and not only that, but like it's more or less an inconvenience. Why do you think that someone hadn't thought of this earlier and had kind of like really explored this concept earlier? Where do you think some of the rub was in terms of friction in making something like this happen?
Yeah, I think it's tough to say, for sure, but I would imagine that most health systems, they know how to operate emergency rooms, and when they do, they know how to operate urgent cares, and they kind of treat them separately. And so for us, we were physician run, we weren't in a hospital when we set up. We didn't know any better. We were just trying to make sure our patients liked the experience, and we tried to do everything that we could to make sure that we didn't have any hindrances to the patient, but we could still provide the clinical care they needed, and then to push that the right way. You fold in the complexity that just comes from the CMS payment system through the conditions of participation and how you do that and how you have to bill. I mean, it's super difficult. I've got multiple pages from different attorneys that we've had to go through and scope this out because it is so different. It wasn't designed for this particular use case, right? And so we're disrupting it. We're trying to charge Medicare, Medicaid, commercially insured people less money for a service. You would think it like is intuitive, which there go our name, to figure these things out. But it's still like when you're on the leading edge of this stuff, you kind of have to wade through a bunch of things and then help regulations catch up to you over time. So one for us, we were competing in a really tough market in our Texas market where we didn't have a hospital flag. And so we just had to get really, really efficient and figure things out and figure out a cost model that would work and all of those things. And so it picked up some bumps and bruises along the way, but it also picked up a lot of tools that allow us to be super successful in partnering with health systems. Now that we know exactly how we want to execute on these things and prove we can do it in market after market.
And how did initially, as you started off with this, how did some of the hospitals react to this new model? What was their initial reaction to this?
Yeah, so obviously the ones who decided to partner with us early on really understood the value prop of what this is. You know, Presbyterian also has a health plan, so they had a another view of things, not just provider but health plan perspective. So they understand, okay, this is where the things are going. We're going to be moving to site neutral payments are going to be challenged for facility fees, for things like imaging. Like you can kind of see that's where things are going, and so some people are early adopters, and some people are kind of wait and see, as we all know. So I think that was part of it. Is they had a good strategic buy-in to knowing this model can live basically on the fence of fee-for-service or value-based. It can be both, right? We can survive in a fee-for-service world and do really well, but we also are a value-based play for larger health systems that are looking to do something that share risk on different contracts and things. So I think that's probably where we're most appealing to most of those partners, is where they're starting to look towards the future. Is it's either put a toe in on the value-based side, or they already have other value-based initiatives, and we kind of fit right in with their overall strategy. And then knowing that we have execution around this little niche market of ER and urgent care, right-sizing that place of service for patients without sacrificing on quality or experience, allows us to really be successful partnering together.
So take me through maybe a use case. If a patient comes in, how do you guys sort of triage and assess to the degree that you're able to without giving out, the secret sauce? Because it seems as though that they can go in from one door, get shipped over to the next area. Talk about that flow from an innovation standpoint. Are there any tools that you're using, or is this very, very decision tree process driven? What is that like?
Yeah, it's actually decision tree process driven. And all patients go through, our full space is a licensed dedicated emergency. There actually is not a separate urgent care space. We do have fast track rooms, which are basically smaller emergency department rooms that we bifurcate similarly to it being two spaces, so that we can operate concentric operating units without overlapping each other. But really for the patient, it's seamless. They show up, they'll get triaged, they'll have a medical screening exam. It's really based off the orders the physician writes to diagnose and treat that patient is what determines its billing. And so the overwhelming majority of patients that come through our centers, which is around 70% nationwide, end up with a lower cost urgent care bill, because that's really the resources they needed to determine what they had going on with them that day. And so that's just kind of a fundamental, fairly way to do things. And also, too, we're bound by EMTALA, so we can't financially screen patients up front as an urgent care could. So this is a way to keep the clinical care continuity going the right way, and then make sure that the urgent care component is really a component of billing that's more of a customer service option than it is a separate operating model. But
there's been a lot of talk around healthcare consumerism, patient experience, and oftentimes I feel like those are just words. How have you guys really embodied that at the core of sort of who you are? Can you maybe give us a little bit of an illustration of that?
yeah, we do survey 100% of our patients post visits, and we kind of come up with your net promoter score, if you would. But it's really an operational tool more than it is a good customer service score. I mean, we told you we had a 75 NPS. People who know NPS think that's great. Some people might think it's a C, even though it's world class from a scoring perspective. But really, it's what you do with that information that makes the difference. So we go through and we trend that information by provider, by staff member, by time of day, by ER, by urgent care, and we learn from our patients too. We have a set expectations that we go through from a training perspective culturally on what the expectation is to work in one of our organizations. putting the patient first and being very others focused versus self focused. But then we follow that up through our customer, listening to our customers or our patients, and then making sure that we are doing things that move that forward, like we would want to be treated if we were the patient, right? So that's really what's been at our core, and we've leveraged that CRM system to help us continue to use it as an operational tool. We firefight any passives or below. So that would be anyone who scored you 8 and below out on a scale of 10, to make sure that we're doing everything that we can. And we can also be able to have coaching decisions or discussions with our patient access staff at the front, the physicians, once we're able to see trends so that they understand how they're being perceived. Because at the end of the day, most people are trying to do a good job and they're trying to provide a good service to patients. They might not understand exactly, how they're coming off or how they're perceived. And so really it's just tying those things together on how we win. We know if we provide a great service, patients will tell a few friends and they'll come see us in their times of need, right? We know if we have a poor job, they'll tell everyone they can get a hold of, like, no, don't go to this place. And when you have our model, which we're taking what could be emergency department revenue, and we're taking 70% of that and saying we will take less for it, it's a volume-based place. So it's really based on putting that patient first, making sure that they understand that's what we want to do, so that they tell a few friends, and we continue to gain market share over time.
And do you find that patients will create more reasons to come back, for the urgent care component, maybe treat it as more or less as a primary form of, I guess, triage? Where are you seeing that? And do you think that this is a trend that you're going to be seeing in the future?
Um, Not really for primary care use for us, because we have emergency department physicians. We're not really going to be there to trend your blood pressure over time. We will make sure we get you into health system primary care to do those things. So really, the patients that come to us are more the episodic in nature. They can't get into their primary care if it's urgent care needs. So think you've got sore throat and headache, and you can't get in to see your primary care. The telehealth option, you don't know if you have strep or flu, so that's not really for you. So you still need to go see someone who can fill that capacity. We're open 24/7, so those things work. And those are the types of patients we see. And if they have a good experience, they come back. And once they understand also what you are, that you have the full emergency department capabilities right there, you have the CT scanner, you have ultrasound, you have advanced labs, and all of those things, they understand they can come here and not have to make that decision. What's the right choice for me?
Right.
That's when they understand it. And then they also get like a little problem, a little bill, a bigger problem. Well, you get an emergency department bill, but it's a good thing you came. So it really kind of wins in all areas. And over time, they just trust you with whatever element might come up that they can't get into a primary care if it's not a small issue. They just come to you and they get the right bill 45 days later, and they're treated well while they're there.
So would have been, from an innovation standpoint, I think when you think about it, as you're evolving and getting better over stretches of time, a lot of the times you're not winning. What would have been some of those learning lessons, some of the valuable ones that you can point out to share with the community in terms of some of these valuable lessons? Maybe initially they were embarrassing at first, but what are some of the things that you think you can share around those lines?
Oh yeah. Well, we all stub our toes if you're trying to do something right, right? You're going to make mistakes along the way if you're trying to do anything that's worthwhile. I'll say you have to be pretty strong in your convictions, but have them moderately held at best, maybe even loosely held. Not every market's the same. Just like I'll tell you some of the things, like just what works in Dallas Fort Worth doesn't mean that's going to work in Albuquerque, New Mexico, or Seattle, Washington, right? So you have to be willing to collaborate with partners and understand and innovate and bob and weave along the way, and have a plan A and a plan B and plan C sometimes too, and learn from those, and then make sure you don't make those mistakes again. When you're doing something new, even if you've had success right out of the box, there's different environments that you just have to adapt to, and you have to constantly be willing to, check your ego and check your bias, really go through and come up with an A and B, talk through with people who are in that particular market if you're going into a new one, just to understand exactly what they're seeing on their local level, and then think through collaboratively with them how you're going to augment to get the results that you both want in that particular case. And so I can tell you from market to market, some of the things look a little bit different. We still are able to get really good outcomes regardless of where we're at, but things are different across the U.S. Not every place is like Collin County, Texas. I can tell you that much. It's definitely a different aspect there. So I think that's probably the biggest lesson learned, and what I've shared to other people who are trying to do something disruptive. You're going to have a good plan. Things will go awry from time to time. It's really how you respond and not make the same mistake again once you make one, because you're for sure going to make one if you're trying.
So what's it been like, being I'll just call it a decentralized uh, care delivery model where you're in multiple markets. How has it been trying to really establish a culture? How has it been trying to keep workforce really engaged and just having a really good solid culture? What's that journey been like? And yeah, share to the degree that you can.
Yeah, we're very fortunate the organization has chosen to put culture first in a lot of these things. We actually have, it's called Intuitive University. We have Enriching Patient Lives for Leaders that our Vice President of Medical Operations, Dr. Adrian Murphy, really helped us codify a lot of what we were doing in our day-to-day and the early on to a curriculum form. And we bring all new leaders across the country to Dallas to come through basically a week-long training. And with peers from across the country, they have some didactic training, they have some shadowing with our sites here in Texas. We have some required reading that we go through, and also from a recruiting standpoint, it's kind of a gauntlet to get hired with us too. You have to go through a number of different interviews. We have one simple rule our executive chairman, Joe Hutz, gave me back in 2014, it's no jerks allowed. And so we really try to screen to make sure that everyone's others focused that works for our organization. And then we also supplement that with a leadership development program through Intuitive University. And then we take that training to the staff level with every opening. And then we follow that up with annual training on those core tenets and values. Because, being a servant-led organization or being a servant-led culture is something you hear a lot. It's honestly, it's a lot of buzz out there, but it
Yeah.
comes down to the execution. It really does. And we empower those leaders at the local markets to own that culture. We provide the different materials for them to do that. And then we also go out and support them. So whether it's myself or our chief medical officer and founder, Jay Woody, going out to the markets every single month. Luckily, we live in Dallas, so it's easy to get to anywhere, but we get a lot of miles on that. But we're out there talking with those frontline leaders, making sure that we're doing our job, which is clearing them the deck for them to execute on the mission. And then, that's if we do those things and we put culture first and we put the patient first along those things, everyone wants to ascribe to those items. It's just making sure it's reinforced continuously. It lets us to have success. It's difficult to do so. It's expensive to fly everyone to Dallas for those trainings 4 times a year, right? But it's really good. And it also gives them a support network of other people in their roles across the country dealing with similar challenges. And so they form tight bonds as well. And they get really energized while they're here and they get able to carry that forward. And it also, they get good face time with Tom Herman, our CEO, myself, Garrett Jackson, our CFO. So it's good, so they get to see us real live, and then we have to practice what we preach in order to have any buy-in overall. So it keeps everyone accountable too. If you're going to be presenting on these items and doing that, you better be doing what you say others should be doing, or otherwise you're not going to get any buy-in whatsoever. So that's really how we focused.
And do you find that keeping that culture and keeping those standards gets even harder as the organization grows? You mentioned earlier that there's a certain number of locations that are going to be opening this year and for the foreseeable future. Is that just the main priority, saying, hey, like, how do we make sure that this culture is not diluted? And is it just continuously doing what you've been preaching, or is it another set of things that when you escalate to a certain other level that you're going to have to start to implement and institute?
So it's a little bit of both. I mean, we have to keep the core intact, but we have to iterate for scale, right? And so
Yeah.
basically, like taking it down to the staff level, we've taken what was super leadership focused and made sure we're hitting people where their feet are. So if you're a frontline nurse or a frontline provider, you've never been like exposed to this type of material first. We've made sure that we're going to hit you at the point that you're at, so that as you progress and move up, in your career, for us, if you go to a clinical manager or a medical director or a program director, you're going to be, a lot of the same types of message on just basically treating people and others well, like that will continually be there. Then we'll give you more tools and things on like your emotional intelligence, be able to scale that as the leader grows over time. So it's, a lot of the same things from the same tenets, but then figuring out how to deliver them more effectively. It's super easy to create a bunch of videos and have people watch a bunch of videos. That's super easy. That's the easy button on culture. We said no to that. Absolutely no. We have to own that culture in those markets. We have to be able to drive that culture for those teams, because they need to see our frontline leaders need to be walking the walk and talking the talk. Like that's the only way that you get buy-in. It can't be from corporate, this is the corporate culture that we're ascribing to you. No, it has to be our culture, and it has to be driven by those leaders that are working where the work is, and that's where we're seeing patients, and that has to be done. And so that's one part that will never go away. We'll probably get some more tools and tricks along the way to make it a little bit easier for that to be delivered, but that's kind of a non-negotiable for us.
That's really interesting. And talk about sort of at the local level, the dynamic. What are these sites comprised of? Or are you talking mid-levels, physicians? You mentioned a few, but what's a typical site look like from a clinical standpoint? How are they staffed?
Yeah, they're staffed just like most emergency departments. We have some different ratios based off of volume tiers that we know are going to be successful for the outcomes that we're going to be held to in these partnerships. But we're going to have emergency room physicians. We'll have some emergency room mid-levels, emergency room nurses. We'll have CT X-ray techs. We'll have patient access staff or your front office staff to go through there, and then you'll have a complement of other things like yes, and things of that nature that we'll roll through. But it's really taking that full clinical care team if you needed to go to the emergency department, but we put it in a 12,000 square foot box. So there's but everyone is there serving that one cohort of patients. No one is distracted with something else. We're there to take care of the patients that show up at those locations. And so we're able to get a lot of efficiencies by really making sure that we're focusing on how do we make sure this patient's journey is one as good as it can be, not have them sit idly if there's a way that we can run things in parallel, right? And making sure we're getting results back faster as physician can act, clinician can act to get that patient to where they need to be or get them dispositioned quickly. So it's really kind of focused on taking all those resources and laser focusing towards the outcome of those patients while they're there in front of us. So we have a unique advantage is that we're not being pulled for ICU patients and outpatients and inpatients. We have one group, and we just make sure we laser focus to take the operational processes to where they'll really line out for those overall outcomes.
And I'm just sort of curious because you mentioned you guys are doing surveying real time, managing for MPS. What have been some of the most interesting comments that you've seen that have come back, and changes that you've instituted, organizational wide as a result of some of those comments?
Yeah, well, they can kind of range. It can be for so much as like room 4 is always cold, and you find out there's an HVAC issue before stuff comes up. So it can be as simple as that, or you can find out that you'll have like a stellar provider who, basically like it doesn't feel like the physician is listening to them. If you go through and then shadow them, you find out that they're not sitting down and talking to the patient. So we've actually created like pearls of wisdom for different feedback that we've gotten over the years. We provide to our medical directors ahead of time, like here are the most common things that we're going to see in this. So here are the things to go ahead and coach providers. Same thing for the nurses. Here's the most common things. And we have scripting that we built around it. So it's really taking that feedback, finding the trends, and then outlaying those out so that we don't have those same stub toe moments, rollout after rollout, because that would be incredibly frustrating for us all. So, I mean, it can kind of range the gambit, and it was not super specific because there are so many like little nuanced items here and there that really make all the difference in the perception of like what that care is. But simple things like really scripting through that, like, hey, we're glad that you're here today. What are you going with? Making sure that we have a smile on our face and go through there. Making sure the provider sits down and talks to the patient, right? Actually sits down, because you can have the same conversation, have the same attentiveness, but if you're standing up, you don't get as much credit for the time that's there. You just don't, because it feels like you're in a rush because you're standing up. That's what you're putting out. If you sit down, you can go through, have those conversations. Same thing with our nurse. Like just having those scripted conversations so they understand, hey, this is what's going on. This is why I'm here. We're glad you're here, and we want to take care of you. So really a lot of scripting around that.
So maybe we take a step back and just think about the future, and your job is as an executor and getting stuff done. Where do you see things? Where do you see potential roadblocks, areas of concern over the course of this next year?
Yeah, I mean, of course, this next year, I think we're always looking at how we can be a little bit better. So we have that continuous improvement mindset. As far as obstacles here in the near term, not too many on the horizon that we haven't already encountered or planned for. It's mainly making sure you keep that quality as you scale in place, making sure the culture stays in place, making sure the execution is tight. So, we have a deep dive team that we have under our VP of implementations and integrations, Brian Olson, that goes through and takes these best practices from across the countries and makes sure that we're cross-pollinating and making every location better. So we're taking steps ahead of time to make sure that we're meeting those things at scale. I think the site neutral payment things that are going on right now and the pressure those are getting actually might give us a little bit more. It might be one of our better business development arms just for some of the stuff that's going on there. So it might be making sure that we keep up with the demand for new partnerships going forward. But we've done a pretty good job of setting our initial scale base down so that we were able to augment as things change. And fortunately or unfortunately, a lot of these are de novo builds, take 14 months to get stood up. So there's more time than we would like at some points to get ready for some of these challenges in there. But I mean, really, it all boils down to make sure that you keep the same quality and same execution as you continue to grow. And when you bring people into the organization, make sure they ascribe to this, servant-led but high accountability environment that we live in. And we find that most people like to win and like to win together. It's definitely a team sport we have here.
Yeah, you said it. I think there's nothing more, I guess what I've seen in other institutions where people end up leaving is there's nothing more demoralizing than when you feel like you're playing a game that's not winnable, versus in contrast, what you're talking about is there's such a, it seems like there's a level of alignment. There's more alignment that's happening within Intuitive. There's just a big focus on that. And I'd even just be curious around retention rates. Are retention rates higher at Intuitive Health compared to other industry standards? I mean, what is the contrast based on some of the things that you guys are focused on?
Yeah, we typically, and I mean, this is, it's a little tough to go through this, but yes, we do have better retention rates typically at our sites than say even our partner locations. Again, part of
Yeah.
that is because we're really laser focused on one cohort, and then like we're pretty maniacal from a cultural standpoint to make sure we get the right fits in there too. But we definitely do a really good job as you compare this to the industry on making sure that we're doing those little things that we know that people appreciate. So, I mean, I can just talk for a day one employee. I've been here for 15 plus years. I've never felt like I've been in competition with any. Like we just want to win together as a team, and that's really how it comes down to the staff level. Like we're not in competition with anybody. Let's figure out how we can make this site the best it possibly can be, so that we have the lowest left without being seen you possibly can have, so that we have the highest patient satisfaction. What are the things that we can do together as a team, and making sure those leaders are celebrating those wins, and copying our founder on emails out to the staff when they get good feedback, and then our founder we make sure to respond back to them and tell them like a great job, like just little things like that, so we are a team. And really, that's what it all boils down to, and that's something that we had to be very protective of. And I told you that it's kind of a gauntlet to come work for us. You got to go through a bunch of interviews and screenings, but we're hopefully that you're committed. And you're committed to the type of mission that we have, which it's getting that right care at the right price close to home, right? Treating people well along the way. If you do that, good things happen.
Casey, it's awesome when people think about innovation. Sometimes they think things that are just so far out there. And my focus has always been let's do the basic foundational things uniquely better and doing it at scale. And you guys are doing that at scale. Can you maybe just for a few moments share a little bit about how folks can follow your work, where they can follow the work of Intuitive Health before we wrap up?
Yeah, for sure. I mean, you can, our website is www.iheruc.com. It's probably the best to follow us there, and on LinkedIn. As for me, I've been here for 15 years, so I don't know if they're gonna have to do much to keep up with me. But no, I think it's just it's a fun organization. It's a fun one to be a part of, just because the culture is so good, and what we're doing, it's one of those rare things in healthcare where everyone wins, right? So the patient wins, the payers of healthcare service wins, the health system wins, the employees win. If you have everything that's kind of guided on a central ethos of putting those things first, it's just a fun place to be with. We're expanding across the country, have some new markets that are launching, and obviously through LinkedIn and on our webpage, those are posted there. But still looking to. There's a lot of greenfield space, honestly. So that's what really keeps me excited. Is it's not just we've got a lot of things going, and that's the end. It's a lot of things going, and there's a lot more room to go. So I'm sure we'll partner with more health systems and maybe even some payers along the way to go through and continue to drive this innovation. So started out with a pretty novel idea, and it's been a fun ride to be a part of, and I know we've got much more to accomplish.
Well, listen, it's been a real pleasure to just sort of track the trajectory of what y'all are doing, and it's impressive. And for those that have tuned in, if you happen to find this conversation meaningful and valuable, would you mind sharing it on social media? Would you mind liking it and even just commenting it and engaging with it in some capacity? And if there are folks that have an interest in partnering and engaging with Casey and his organization, you now know how to reach him. So Casey, it's been a pleasure having you on. I'm looking forward to maybe having you come back in the future, sharing
Cool.
future updates, and who knows, maybe you guys have Illinois tagged as a green space, and nice to hang out in person
This would
again.
do really well outside of Chicago. I can guarantee that. We just got to find a way in.
Amazing. All right. Well, hope to talk to you soon. Thanks for coming on.
Thanks, Michael. I appreciate it.